Hello, everyone. Our topic today is about nausea and vomiting in the palliative setting. These are the objectives of our presentation today. Prevalence. Nausea and vomiting are common and distressing symptoms reported by cancer patients and affecting up to 70% of patients in the last months of life. Nausea is often associated with chemotherapy and other oncological treatments and may develop chronically because of the progression of the disease being multifactorial. Nausea may also be reported in patients with progressive neurological diseases such as central nervous diseases, peripheral nervous diseases, dysfunction of neuromuscular junction, and muscle diseases. So the commonest two diseases that's causing nausea and vomiting are cancer and the cancer-related therapies and neurological diseases. Definition. Nausea is an unpleasant sensation. It is a subjective phenomenon. Unpleasant sensation of the need to vomit associated with a decrease in gastric tone and peristalsis and an increase in the tone of the duodenum, frequently expressing autonomic symptoms such as pallor, cold sweats, tachycardia, and diarrhea. Vomiting is an objective phenomenon. Expulsion of gastric contents through the mouth caused by forceful and sustained contraction of abdominal muscles and diaphragm. Retching is also an objective phenomenon. It's an attempt to vomit without bringing anything up, and it's characterized by spasmodic movement of the diaphragm and abdominal musculature with the glottis closed, denoting the labored rhythmic respiratory activity that frequently precedes emesis. Again, nausea is subjective. Vomiting and retching are objective. The anatomy. So to really understand, nausea and vomiting, you have to understand both the anatomy and the physiology of nausea and vomiting. So we're going to show you some pictures here, and this will be more clear to you than just stating the facts here. So this is your brain, this is your cerebellum, this is your fourth ventricle. Okay, look at down here. All right, this is the medulla, and this is your vomiting center. The vomiting center is the center of all central nervous system and peripheral nervous system connections here. That's the boss. Okay, behind the vomiting center and outside the blood-brain barrier, there is something called the chemoreceptor trigger zone. Okay, and it's very near to an area called area posteroma. Okay, and then so this the chemoreceptor trigger zone is outside the blood-brain barrier. And then you have the nucleus tractus solitarius. This is the nucleus, sensory nucleus for the vagus. All right. And basically, the area posteroma and the tractus solitarius are the dorsal vagal complex. So I hope this is kind of clear because we're going to work on these, centers just soon now. Triggers for nausea and vomiting: the GI tract, the cerebral cortex,
the chemoreceptor trigger zone, the vestibular apparatus, the vagus nerve, the glossopharyngeal nerve, the splanchnic nerve, and lastly, and as I said, this is the big boss here, the vomiting center. Another nice picture showing the centers outside and centers inside the blood-brain barrier. So inside the blood-brain barrier, we have the cerebral cortex, we have the vestibular apparatus, and of course, we have the big boss, the vomiting center. Look here. Cerebral cortex is affected by psychological factors such as fear, for example. Uh, Vestibular apparatus is affected by motion sickness and possibly by cerebral tumors. Okay, outside the blood-brain barrier here, we have the chemoreceptor trigger zone, which is affected by drugs and metabolic abnormalities. We have the GI tract, which is also affected, especially by distension, all right, or spasm. And then you have the vagus and splanchnic nerves are also irritated by gastric irritation or GI distension. And here the receptors for each of these, centers. The neurotransmitters for vomiting are basically serotonin, 2, 3, and 4, especially 3, muscarinic, M1, 2, and 3, histaminic, 1, dopamine 2, opioid, mu2 receptor, GABA, GABA A receptors, substance P or neurokinin 1, cannabinoids. Receptors associated with nausea and vomiting. Again, the same receptor we just mentioned, like acetylcholine, histamine, 5-hydroxytryptamine, mu receptors, neurokinin, GABA A receptors. Another nice picture here showing the triggers, showing the receptors, and showing the vomiting center. Okay, here is the chemoreceptor trigger zone. This is the area posteroma, nucleus tractus solitarius, vomiting center in the medulla. All right, and these are the nerves that can stimulate the nausea and vomiting here. So it's kind of a complicated, structure. However, if you remember the receptors that are affected, you'll be able to, prescribe the appropriate medication to the patient. Okay, chemoreceptor trigger zone is sensitive to chemical stimuli and lies in the floor of the fourth ventricle in the brain stem and is able to stimulate the vomiting center. This area is outside the blood-brain barrier and is bathed by the systemic circulation. Chemoreceptor trigger zone contains emetic receptors for dopamine, dopamine 2, serotonin, 5-hydroxytryptamine 3, acetylcholine, and mu receptors, which when stimulated provide input for the vomiting center, sited in the third ventricle. High plasma concentrations of emetogenic substances such as calcium ions, urea, morphine, and digoxin may stimulate the dopamine receptors in this area. The chemoreceptor trigger zone is implicated in delaying the reflex of gastric emptying and production of taste aversion, which could contribute to vomiting. Acoustic neuroma, bone metastasis at the base of the skull, brain tumors, or metastasis affecting the vestibular apparatus are possible other causes for vestibular stimulation of H1 receptors and muscarinic cholinergic receptors. So when you do vestibular stimulation, you affect both the histaminic receptors and the muscarinic receptors. In addition to the direct afferent pathways from the GI tract to the vomiting center, the anatomical region of the area posteroma receives emetic impulses from the pharynx, heart, peritoneum, mesenteric vasculature, and bile ducts. Impulses from these peripheral receptors are also transmitted directly to the vomiting center. So area posteroma, which is basically in front of the chemoreceptor trigger zone, receives a lot of impulses from the GI tract. Moreover, it also receives input from the vestibular apparatus of the vagus. Drugs, particularly aspirin and opioids, are able to directly stimulate the vestibular apparatus, which in turn uh, provides input to the vomiting center. So that's why when you have salicylate poisoning, for example, you get tinnitus. Deeper layers of the area posteroma are partly formed by the nucleus tractus solitarius, which is predominantly containing serotonin receptors and is considered the main central connection of the vagus. Visceral efferents impulses arising from the GI tract may reach the medullary vomiting center by the way of the vagus without traversing the chemoreceptor triggers. So some of the impulses go directly through the vagus to the vomiting center. Again, triggers that stimulate chemoreceptor trigger zones, glycosides like digitalis, opioids, ergot, chemotherapeutic agents, salicylates, metabolic abnormalities, especially uremia or hypercalcemia, hypoxemia, and radiation sickness. We'll continue the pathophysiology here. And again, the receptors in the GI may play another important role in the pathogenesis and treatment of nausea, particularly the receptors, the 5-hydroxytryptamine 3, 4, and D2 receptors. Activation of the D2 produces gastroparesis. That's why we give D2 antagonists, right? Vagus receptors include 5-hydroxytryptamine receptors, which are emetogenic, and 5-hydroxytryptamine 4, which enhances the propulsion. So I know it's getting a little bit confusing, but remember this. 5-hydroxytryptamine 3, these are emetogenic. In other words, to get rid of the nausea and vomiting, you have to give anti-5-hydroxytryptamine 3, while 5-hydroxytryptamine 4 enhances propulsion. So I would like to see a drug that enhances or is a 5-hydroxytryptamine agonist to enhance the propulsive motion in in your gut. All right. To summarize, nausea and vomiting are influenced by a complex network of central and peripheral factors that interact with each other. Again, I'm gonna skip some of these slides and we get into the assessment. Like pain, nausea is a subjective experience and presents all of the problems inherent in measuring pain.
So that's why we measure it like 0 to 10, okay, from a scale 0 to 10. Remember, nausea is subjective. Vomiting and retching are objective. So this could be part of your ACES. You have to take a good history and physical when you have a patient with history and nausea and vomiting, especially medication, and drugs that the patient is on. Because a lot of these drugs, like chemotherapeutics, opioids, tricyclics, may induce gastric stasis, NSAIDs could be irritating to the stomach, and so forth. Again, neurological diseases induces nausea. Movement can induce nausea, what we call, motion sickness. Candidal infection might cause pharyngeal irritation, activating the arm of the vomiting circuit as well. Of course, the commonest, two diseases we talked about, cancer and neurological diseases, are the main causes of nausea and vomiting. Also, some electrolyte imbalance, such as hypercalcemia, for example. Vomiting, again, is different than nausea, and there is some debate whether they have the same pathophysiology or not. Vomiting is an active process, and the same thing is retching. A patient that has spinal cord lesions above T5 may isolate the spinal sympathetic control from the influence of the higher centers, resulting in delayed gastric emptying and delay in the duodenal progression. Chronic constipation may worsen the clinical picture, possibly facilitating the development of nausea and vomiting. Neuropathies are frequently encountered in patients with cancer. Autonomic failure is another important cause for nausea and vomiting, and it's a common finding in advanced cancer patients. Drug-induced nausea. We talked about this. Drugs such as opioids digitalis, chemotherapeutic agents such as cisplatin remain the major offenders. Opioids have central and peripheral actions. Centrally, they stimulate the emetic center via D2 or dopamine 2 receptors of the chemoreceptor trigger zone. So I want you to remember the chemoreceptor trigger zone, is the site where medications and metabolic abnormalities can cause nausea. It's through the chemoreceptor trigger zones. So we'll start with the management here. First of all, like anything else, like dyspnea, like pain, or whatever, perioditis, you have to treat the reversible causes of nausea and vomiting. Long periods of repeated episodes of vomiting can lead to dehydration. To avoid this, you have to replace the fluids and correct the electrolyte imbalance. So, if you have a condition like hypercalcemia, for example, you should treat it with bisphosphonates. If you have anything that's like psychological factors contributing to nausea, then you have to work on
a calm and reassuring environment, possibly giving benzos, and so forth, to help with the nausea and the vomiting. Signs of nausea: restlessness, fatigue, increased salivation, urge to vomit, loss of appetite, headache, dizziness, excessive sweating, burping, and abdominal pain. All of these are basically autonomic symptoms that are associated with nausea. Again, nausea is subjective. Vomiting and retching are objective. Complications of vomiting could be nutritional, like weight loss and failure to gain weight, oropharyngeal, like dental and sore throat, esophagitis, esophageal hematoma, Mallory Weiss tears and Boerhaave's rupture, metabolic, like pre-renal azotemia, if you get dehydrated, and electrolyte imbalance, like hypokalemia. We're going to get into important topic here, which is the chemotherapy-induced nausea and vomiting. And we have 5 categories. We have the acute, delayed, anticipatory, breakthrough, and refractory. You need to learn this as a palliative physician. Acute, the onset is within 24 hours. Delayed, usually 24 hours after chemo. Anticipatory is a conditioned or expected response occurring before chemo. Breakthrough is occurring when prophylactic antiemetic treatment fails and rescue antiemetics are needed. And then refractory occurs when the antiemetic regimens failed in previous chemotherapy cycle. Also, we have grading for chemotherapy-induced nausea from grade 1 to grade 4. Grade 1 is 1 to 2 episodes per 24 hours. Grade 2, 3 to 5 vomiting episodes. Grade 3, more than 6. Grade 4 is vomiting that's compromising life. Pharmacological agents for chemotherapy-induced nausea and vomiting. For patients receiving highly emetogenic chemotherapy, the recommendation is neurokinin receptor antagonist, 5-hydroxytryptamine 3 receptor antagonist, and dexamethasone. For patients receiving moderately emetogenic chemotherapy, 5-hydroxytryptamine receptor antagonist or dexamethasone is recommended. Again, this is just how these drugs work. The histamine antagonist, the dopamine antagonist, the cannabinoids, neurokinin 1 antagonist. Benzodiazepines work at a higher cortical center. Pharmacological agents working on CIMV, serotonin receptor antagonists like ondansetron, granisterone, palinosterone, neurokinin 1 antagonists like aprepitant and others. 5-hydroxytryptamine neurokinin 1 combinations, corticosteroids, and olanzapine. There's a lot of interest on olanzapine nowadays, guys. So again, generally widely accepted management guidelines are not available except for the treatment of nausea and vomiting associated with chemotherapy. So, chemotherapy-induced nausea and vomiting, we have guidelines that you guys need to follow up on, especially with the ASCO. They publish guidelines, every few years here about nausea and vomiting in cancer patients. Again, these are the different,
triggers to the vomiting center. Remember, to make it easy, vomiting center is the boss. All of these are just serving this big boss here and are triggering the vomiting center to cause nausea and vomiting. And basically, you need to be aware about the different receptors because you're going to give medications that block these receptors. Okay? Antiemetics. I put only the commonest ones, like metoclopramide, haloperidol. In the exam in general, guys, the first line of therapy is metoclopramide and haloperidol, followed by others like olanzapine, ondansetron, and so forth, just to make it simple for you. And this is basically the receptors that these are working on. Benzodiazepines are used in patients with anticipatory nausea and vomiting. And we see this usually in younger age. Also, patients that have, high level of expectation of side effects, and patients that has history of motion sickness. Usually, we give lorazepam, Ativan, before the chemotherapy. Prokinetic agents such as, a dopamine 2 antagonist and 5-hydroxytryptamine receptor agonist. One of these drugs is metoclopramide. All right. So, of course, this is a great drug, but because of its D2 antagonism, it can cause extrapyramidal symptoms. But it's a very good prokinetic agent. There's another drug similar to metoclopramide. It's called domperidone. This one is also a D2 antagonist, but it doesn't cross the blood-brain barrier like metoclopramide, and thus the extrapyramidal, side effects are much less. Metoclopramide tablets, and it comes also in IV form. Be careful when you inject it IV because there are case reports. If you do it like a push or a bolus, you can cause arrhythmias because metoclopramide has some chemical similarity to procainamide. Domperidone is the cousin of metoclopramide with less extrapyramidal side effects. Adverse side effects of antipsychotics in general, higher risk of neurological side effects, second generation like olanzapine, higher risk of metabolic side effects. D2 antagonists, again, the commonest ones are butyrophenones like haloperidol and phenothiazines. Haloperidol is the drug of choice in nausea and vomiting. It's a butyrophenone. It's metabolized by 3A4. It can cause, QT prolongation. Phenothiazines, such as chlorpromazine. Another drug, levomepomazine. It's a phenothiazine, and it's available in some like European countries and Canada. And this drug, in fact, can be used for palliative sedation. Olanzapine is a D2 and 5-hydroxytryptamine 3 antagonist. And there's a lot of interest on olanzapine nowadays. Haloperidol, chlorpromazine. The nice thing about haloperidol, we can give it as a syrup, we can give it as a tablet, we can give it as an injection.
And then you have chlorpromazine. Unfortunately, chlorpromazine has to be given IM only, and it can cause hypotension and oversedation. Levomepramazine. Olanzapine is a drug of choice nowadays in patients with, difficult nausea and vomiting. It became like one of the first agents to be used. This one, the IM, we don't use it except for agitation, but I just put it there for the sake of completion. All right, this is for agitation, guys. Okay, this one is the one that we use, especially the sublingual one. Okay, and again, number of studies supported the use of olanzapine. It promotes appetite, reduces nausea, and promotes sleep. Antihistaminics like promethazine, Phenergan, and this is again is one of these phenothiazines. Cyclizine is an antimuscarinic agent useful for bowel obstruction as well as movement-related nausea. Cyclizine, promethazine, or Phenergan. Promethazine, Phenergan can be given IV here. Anticholinergics, such as hyoscine and butyl bromide. Hyoscine, butyl bromide doesn't cross the blood-brain barrier and is less sedating than hyoscine. Scopolamine patch. I'm not sure if you guys used it or not. We use it behind the ears, 1 milligram every 3 days. Buscopan, famous drug, or hyoscine butyl bromide. And then you have scopolamine hydrobromide.
Salam.
Neurokinin receptor antagonists, like they're very expensive, but they're very useful, especially in chemotherapy-induced nausea and vomiting. Drugs such as aprepitant is, in fact, one of the most important and useful drugs in chemotherapy-induced nausea and vomiting. Oral olanzapine was significantly more effective than oral metoclopramide at controlling both emesis and nausea in patients receiving highly emetogenic chemotherapy. While those that develop breakthrough chemotherapy-induced nausea and vomiting, despite guideline-directed prophylactic anti-emesis. This is aprepitant. I mean, I don't use it personally, but the oncologists use it all the time. Serotonin receptor antagonists, like we call them the cetrons. We have a bunch of them: ondansetron, granisterone, tropisterone, and palonsterone. This one is the strongest of them. They all prolong the QT interval, by the way. All of you are aware about the ondansetron and Zofran. Granisterone, there's a patch, granisterone patch. And this one is injection palonsterone. This one has longer duration and is more potent than the ondansetron and the granisterone. Steroid. Dexamethasone has synergistic or additive antiemetic effects when it's combined with cetrons, metoclopramide, or phenothiazines. Dexamethasone can be given orally or injection, subcut or IV. Cannabinoids. These have a low antiemetic efficacy, but it seems like they might be useful in, especially in HIV patients, and also and sometimes in in chemotherapy-induced nausea and vomiting. The most famous one is dronabinol, and it's been used in diffuse metastatic disease in the GI tract for intractable nausea and vomiting, responsive to conventional antiemetics. I used this drug, by the way, a lot when I was back in the United States. It's not addictive, by the way. It's not an addictive drug. Complementary therapies, a range of healing philosophies and approaches that focus on holistic therapies. I haven't really go too deep in these because of the time frame of the presentation, but I'm going to mention the commonest two ones that you need to know about. Number one is the ginger, or the it's the ginger, and also the ginger ale. All of you guys are aware about ginger ale, right? I mean, in old days, we used to give it routinely after surgery, ginger ale, okay, because of its power to reduce and treat nausea and vomiting. And ginger, I mean, it's available in all Chinese restaurants and Japanese restaurants. Okay, acupuncture. I don't want you to, I want you to remember only one point. Okay, it's called the pericardial 6 because there's so much literature behind this point here, the pericardial 6. And this is how you measure it. Put 3 fingers and then put your thumb there and rub it in a circular motion. Key learning points. Nausea and vomiting are common and distressing symptoms reported by cancer patients and affecting up to 70% of patients in the last months of life. A multitude of medications, including opioids, digoxin, antibiotic, cytotoxic, can cause nausea and vomiting on the chemoreceptor trigger zone, whereas non-steroidals, iron supplements, antibiotics can damage gastric mucosa. The following pharmacologic agents are recommended: neurokinin receptor antagonist, 5-hydroxytryptamine antagonist, dexamethasone, and for patients receiving moderately immunogenic chemotherapy, a 5-hydroxytryptamine receptor antagonist or dexamethasone is recommended.